I would like to introduce and welcome our moderators for the session, Dr. Chesta and Dr. Thankaraj. Good evening, sir. A warm welcome to you. And our session coordinators, a warm welcome to you as well, Gauri Chawla and Dr. Srishti Sudan. Now, I would like to hand over the virtual dais to our moderators, and they would welcome the chairperson, followed with the speakers. Over to you, ma'am. Thank you. Over to you, sir. Thank you.
Thank you, Himay. And namaste and a very warm welcome to one and all to the LMHI Global Colloquium 2021. Taking the discussion further from our earlier session, this is about the experiences of acute and long COVID-19. COVID-19 has affected the entire globe and continues to do so. And from our experience of last 1.5 years, we have seen that homeopathy has played a vital role in prevention, treatment, and in combating the after effects of COVID, more so with so many emerging variants every day. This session would be talking about the same. Here, we'll have 7 speakers who are working in different setups at various levels in the public health, and they would be sharing their experiences. The session would be chaired by Dr. Lex Rattan. Welcome, Dr. Lex. Dr. Lex had graduated as medical doctor in 1977, as GP in 1978 from Netherlands, and he had been working as a homeopathic physician since 1983. He is the coordinator of LMHI COVID-19 data collection team and produced a Bayesian mini repertory for COVID-19 and the corresponding app. Welcome, sir.
Thank you, Dr. Shasta.
Now, taking the session forward, we would like to invite our first speaker for the day, Dr. Meeta Gupta. Dr. Meeta Gupta is Chief Medical Officer, NFSG, and she's working at the Director.
Sorry to interrupt. First speaker is Dr. Harleen Kaur.
Okay. As per the data available with us, it was your name, ma'am. So no worries. We have Dr. Harleen as well with us. Welcome, ma'am. Welcome, Dr. Harleen. Dr. Harleen is a research officer homeopathy working with the Central Council for Research in Homeopathy at New Delhi. And she would be presenting an article on homeopathy as an adjunct to standard of care in moderate and severe cases of COVID-19, a single blind randomized placebo-controlled study. Over to you, Dr. Harleen. Dr. Harleen, you need to unmute.
Yeah, thank you so much, Dr. Cheshta. And thank you, Dr. Meeta, for actually, she was supposed to speak first, but then I have another session, another talk in another session, which is going on parallelly in hall 2. So I will have to switch. So thank you so much for making room for me. Quickly, if I can just share my screen. Just quickly beginning with the presentation, before I do so, I would like to thank LMHI organizers and all the chairs and coordinators, everybody who's been, really toiling a lot for this particular event, and it's showing, how effective it is going to be. It's all clear. Thank you so much for this opportunity, and I would now begin with my presentation, which is on homeopathy as adjuvant to standard of care in moderate and severe cases of COVID-19. This particular study was conducted in Haryana, which is 40 kilometers from New Delhi, at one of the institutes of repute, All India Institute of Medical Sciences. It's a branch of New Delhi All India Sciences. And this here you can see the team, the entire team, which includes Dr. Subhash Kaushik, Dr. Gurpreet Singh, Mr. Arvind Kumar, Shweta Singh, Dr. Tanya, Syed, Khushbu, Maneet, Naval Kumar, Dr. Sushma Bhatnagar, and Dr. Amit Khurana, who's also been mentored throughout the study. So quickly, a background of the study. So there have been several attempts that have been made to prevent and treat COVID-19, but this is one of those situations in the history of mankind when enough is not enough. This protocol was conceived rather early in June 2020 when coronavirus infection had just begun to show its true colors in India. And CCRH, being a research body, wanted to help ailing as well as produce some evidence-based data for homeopathic treatment for COVID-19. The study was registered under Clinical Trial Registry of India and was funded by Ministry of Ayush through Central Council for Research in Homeopathy. We had a very simple objective of evaluating effect of homeopathy treatment in moderate and severe cases of COVID-19. Why we picked up moderate and severe cases was that, if we show some efficacy in mild and moderate, science could always say that, no, I mean, mild and the more mild and asymptomatic cases are anyways spontaneously recovered. So your efficacy is still questionable. So we thought, let's try if we can do something with the moderate and severe cases as well. So, primary outcome was to convert RT-PCR COVID-19 status to negative, which was actually the only, back in June 2020, this looked like the only thing to achieve as an outcome for COVID patients, which was actually not true eventually, that we learned. But and secondary objective was to do a comparative assessment of clinical condition through WHO's scale of clinical ordinal outcomes and through patient-oriented measured yourself medical outcome profile, and also to assess the changes in laboratory parameters, including biomarkers for inflammation and coagulation. Sorry. Yeah, so inclusion criteria was simply COVID-19 positive patients, RT-PCR positive, moderate or severe COVID-19 patients, as per the criteria laid down in the guidelines issued by Ministry of Health and Family Welfare on 13 June 2020. And we consider the case moderate if SpO2 was less than 94% and respiratory more or equal to 24%, and severe if respiratory rate was more than 30 breaths and SpO2 less than 90%, and also with symptoms of ARDS. So we excluded the children and adolescents that were under the age of 18 years, pregnant and lactating women, and not willing to give consent for an adjuvant treatment, and those who had the inability to be contacted for clinical outcome after being discharged. Cases in which, in the opinion of the clinical team, progression to death was imminent and inevitable within the next 24 hours. And the intervention that we used was simply individualized homeopathic treatment that was given in the potentized form, mostly, and sometimes in mother tinctures form as an addition to the potentized medicine. And we were generally giving the medicine 2 hourly in most of the cases. So we use the statistical techniques like mean difference and standard deviation that we calculated for all the baseline parameters. And we use independent sample t-test and chi-square test for parametric and Wilcoxon sign rank for non-parametric. We also, since this included survivals, we also included the survival analysis through Kaplan-Meier for non-parametric evaluation, and we used repeated ANOVAs for parametric analysis. The randomization was through computer-generated list, and the allocation was 1:1. This was the flow chart of the patients. We assessed them for eligibility. We screened about 556 patients, out of which we had to exclude 406. And we finally enrolled 150 patients, out of which 75 were divided equally into control and placebo groups each. And we allocated add-on homeopathy treatment in addition to the standard treatment to the intervention group, homeopathy group. Right, so these are the baseline characteristics for you for the frequency of presenting complaints and baseline data in terms of the lab values. You can see that, interestingly, we don't see fever as a very common presenting complaint in moderate and severe cases. Reason being, the patients, by the time they're hospitalized, they're suffering with more of cough and breathlessness as compared to fever. So fever was not a very common presenting complaint on the 5th, 6th day of the infection when they were hospitalized. And you can see that the baseline parameters for ferritin, LDH, T-dimer were quite competitive for both the groups. And as goes the knowledge, we had about 58 years of age as the average age for the patients, and men were, of course, more affected than the women in our group, study group, and we had like moderate cases were equally distributed, and we had a little of severe cases disparity in this. Blame it on single blind study that we think was the reason. Right. So here we have the results in which we have the RT-PCR conversion rate of a significant one, which is P less than 0.012, with a difference of about 3 days in the two groups. So you can see over here that during the ninth day, we had most of the patients who were recovering from their RT-PCR status, while in the AOH group, that was around 12.3 days. Mortalities were around 13.6% in our study, which was still far less than what is reported in the hospitalized patients. But we have to understand that we are talking only about moderate and severe cases. So this percentage is only concentrated to those cases where we, for the moderate and severe ones. But here we had 7 mortalities in our study group, while we had as many as 13 in the placebo group. And you can see that even the transfers to mechanical ventilators were lesser in the add-on homeopathy group, which were like only 4 in the homeopathy group and 8 in the control group. And eventually all the MV transfers also culminated into casualties. So we can actually, considering this, that we were giving an holistic treatment to the patients, and we were talking about immunosuppressed patients where they were very close to multimorbidity in the body with cytokine mayhem. Probably this holistic approach did what it did. Right. For the WHO clinical outcomes ordinal scale, we started from grade 4 or grade 5. You can see that the moderate or severe cases will be oxygenated, will be given oxygen therapy in the hospitals. So we would, to begin with, all our patients had a grade of 5 or 4 in the WHO's scale. But eventually, we could bring more patients within 28 days of follow-up period. We could bring more patients in the recovery score of 3, and that too in a lesser time. For MyMop, we could see that a subjective feeling of improvement was very well reflected in the homeopathy group as compared to the control group. Most of the patients reporting immediate relief after a few doses of homeopathy. These are the lab parameters that we took as secondary outcome, but over the course of the study, we realized that our secondary outcomes are going to be very important for assessment of the whole overall efficacy of the study, because RT-PCR status, we could see that there are a lot of patients who were RT-PCR negative already were also passing away. So we realized that the significance of conversion of RT-PCR status might not be really directly proportional to the recovery of the patient. So we tried to be very meticulous with the recording of lab data as well, so that we can see what's happening to the secondary outcome of this particular study. And then we could see that a lot of lab parameters, almost most of the lab parameters that are commonly done in these cases we could see a positive trend of the homeopathy group with recovery in all the scales like CRP, interleukins, and D-dimer, ferritin, fibrinogen. But we had a statistically significant results in 5 of these report parameters: CRP, fibrinogen, TLC, alkaline phosphatase, and platelet count. Over here, we can see that improvement was considerable in CRP, which is basically a very, very early predictor for severe COVID-19. And for TLC, we know that leukocytosis with lymphopenia is associated with higher chances of developing severe illness. For platelet count and fibrinogen, we know that if we have a low platelet count and a high serum fibrinogen finding, then we are going towards coagulopathy in the patient. So this again is quite finding a significant difference in the two groups with this reading was also very encouraging for us. And we also could see less of liver toxicity through which is indicated by serum alkaline phosphatase. We found that the homeopathy group could actually, they had lesser levels of serum alkaline phosphatase, so which indicates that probably we could check the damage that that the disease was causing directly or indirectly to the patient. Probably we could restrict the use of drugs or maybe the dosage of drugs in those patients that we were giving homeopathy to, or it was the direct effect of the virus. This remains to be further checked. These were the homeopathic medicines that came out to be effective, and we frequently prescribed it. So Viratram Viridae was one of our top scorers in the list of the prescriptions, followed by arsenic album and bryonia. And among mother tinctures that we prescribed, aspidosperma and lobelia were the most prescribed drugs. And this is actually much before that. In India, this aspidosperma video went viral, saying that if you take this, you would not need to be hospitalized, which is not the case, which was a little misleading. But we could see the result of aspidosperma in our patients in the sense that the transient relief that we could see was very encouraging with aspidosperma. And even for Viratram Viridae, in severe cases, we really found, that there were patients who were not really put on, they were not on NIV or not, the non-invasive ventilator, but they were simply on mask or a high flow nasal cannula. So those patients were actually allowed to go for, their to the washrooms on their own. So what we would do is that we would ask those patients to just take, a few pills of Viratram Viridae before they do go for any physical exertion, and then come back and see their SpO2 levels, whether they are actually dropping to the levels that they were dropping before. And we witnessed that by ourselves. We we used to give the patient the dose, and sometimes we were there to see that what happens. So Viratram Viridae was doing a good. Good help on that in that sense. And even for aspidosperma, we could see that there were patients who were, literally panting in front of us when they were on hospital beds and all. They could basically at least sit up and calm down a little with the breathing, respiratory rate going a little lesser. So this is what we could practically see. But, our aim was to overall find out whether homeopathy as a whole is working in COVID-19 patients and not really zero in on the drugs, which could be a next level of aim now that we know that the group of medicines that work well are identified.
Dr. Kaur, the time is up, so could you please
Yeah.
sum up? Thank you.
Yeah, I would just sum up. These were the indications, so I'm just going to skip through these, and these are my points that I would like to just emphasize. That we could basically RT-PCR, even if it is negative, patient could still have a very uneventful future, and better clinical improvement with lesser mortality speaks in favor of enabling homeopathic treatment in an integrated mode in the COVID-19 patients. And this is one patient, if I may be allowed to just quickly go through.
Thank you, Dr. Halim.
Yeah.
I
Yeah.
noticed that the number of Viratram prescription was rather high. Does that have to do with the number of severe cases?
But you're talking about potency? I didn't get the question. If you
Sorry, the number of Viratram prescriptions.
Number of
that was higher than in
Viratram
most.
prescriptions, right. So yeah, we gave Viratram more to the severe cases than to the moderate cases. But even in moderate cases where breathlessness was very, very evident, where they could not speak because of breathlessness, and they would, we started with Viratram Viridae before we shifted to some other medicine to just stabilize the patient for their lung condition.
Okay, because it's higher than in most other data collections, I
Yes,
noticed.
yes,
That,
that's true. For Bryonia, Gelsemium, and arsenic, I think we are in sync with the other studies that are there. But Viratrun viride is something that is, but I wonder if we have a lot of data on the severe cases where we can actually explore this.
yeah, I saw there were more severe cases in the Viratrun group.
That's
And well, it's very well to have these randomized placebo-controlled trials. Also, the size of the groups seems a bit low. Was there a special reason, or was that for ethical reasons?
Sample size that we estimated to be we calculated the sample size, and it was calculated to be 128. Though we increased it to 150 because we were expecting a lot of dropouts in the beginning. So
Yeah.
we took ethical committee's clearance to increase the sample size to 150, which we eventually did. And that was based on a statistical calculation. So there were no other reasons for taking 150 as a sample size.
Okay. Thank you very much.
All right.
Thank you.
Ladies, gentlemen, sorry to intervene here. The small announcement, if in case the Zoom meeting ends abruptly, if it shuts, so do not panic. You can log in with the same ID again, because Zoom has a tendency to shut on its own after 24 hours. It may happen anytime, anywhere. So, ma'am, we can continue from here. Thank you.
Thank you, Himay, for the update. Now we have our next speaker, Dr. Meeta Gupta. Dr. Meeta is working as Chief Medical Officer NFSG with Directorate of Ayush, Dr. B.R. Sur Homeopathic Medical College Hospital and Research Center, New Delhi, India. The title of her abstract is Homeopathic Remedies in COVID-19 Prognostic Factor Research. Over to you, Dr. Meeta Gupta.
Thank you, Dr. Cheshta. Is it okay?
Yes, ma'am, it's visible. You can go ahead.
Okay. A very good morning, afternoon, evening to the chairperson, moderators, all speakers, and all the delegates from across the world. Today, I will be speaking on homeopathic remedies in COVID-19 prognostic factor research. This study was actually started after we got the permission to prescribe homeopathic medicines along with the standard conventional treatment. This was as per the policy of the Government of India, where they formed an integrated team for the management of COVID-19. As a result of which, our medical officers were, all the Ayush medical officers were posted in various COVID care centers and quarantine centers, testing centers. By virtue of this, they were able to interact with patients and collect data from them, like their symptomatology, and they were the privileged ones to treat also those patients. So we decided that if we are getting this data and we are able to treat patients, then we should do it systematically. So we decided to start this project, this study, under the mentorship of Dr. Lex Rattan and all those medical officers who collected this data. This study has already been published in Journal Homeopathy, and on behalf of all the authors of this study, I am presenting this today in this colloquium. So this study was basically aimed at the systematic collection of data based on the prognostic factor model. The prognostic factor research is an important technique for analysis of cohorts of good quality cases. Prognostic factor is the thing which characteristic of patient that can be used to estimate chance of recovery from a disease. Usually in normal practice, the physician's prescriptions are based on the specific symptoms of patient. They expect that medicine will work based on experience, that specific symptoms of patient indicate specific medicines. Prevalence of such symptoms is higher in population responding well to specific medicine than in the remainder of the population. These symptoms can be considered as prognostic factors, and they play an important role in accurate prescribing in cases of RCTs. The objectives of our study were: the primary objective was to identify clinically useful homeopathic remedies and their characteristic indications using the prognostic factor research model for COVID-19. The secondary objective was to catalog the symptomatology of disease. The study design and settings: this was an open-label, multicentric observational study, analysis was done based on the data collected between April 2020 to July 2020, which was the first wave of COVID-19. Informed verbal consent was obtained from the patient, and those who were willing to take homeopathic medicines were prescribed along with their conventional protocol, in which allopathic medicines were prescribed. At that time, during the first wave, usually the symptoms were very mild and very rarely severe cases were seen. So at that time, no steroids or antiviral drugs were routinely prescribed. The main medicines which were prescribed during that time, they were paracetamol, anti-allergics, antibiotics, and multivitamins. So our prescriptions were based on individualization, and they were left to at the expertise of the treating doctors to prescribe what they seem right for that particular patient. The data collection was done by 28 homeopathic medical officers who were posted at 23 integrated COVID care facilities, which may be testing centers, COVID care centers, or quarantine centers. From there, all the data was collected. And the recording and analysis of cases was done in a specially designed format. And this was prepared in consultation with all medical officers based on their experience in the integrated facilities, like the type of patients coming to their facilities, the main symptomatology of the patients, the common medicines which are prescribed. In that case, a special Excel sheet was formed on which the data was collected. The participants included all RT-PCR confirmed positive COVID-19 patients who were treated at COVID care centers and in home isolation. All patients of mild to moderate disease were included, but not of severe diseases. The mild cases were classified as per the Government of India guidelines, which included those cases which do not show any sign of pneumonia, and moderate cases were patients who were showing signs of pneumonia but not of the severe disease. However, the patients with comorbidities belonging to mild to moderate category were included. The variables used for the study was demographic profile and clinical presentation of patients, and homeopathic medicines and their indications that can be used as prognostic factors. In this, the methodology adopted for data collection was a long procedure. First of all, doctors were trained in data collection at the start of the study. After that, an Excel spreadsheet was shared with all doctors who on a daily basis added data of their respective cases from their centers. This spreadsheet contained 71 fields covering a spectrum of COVID-19 symptoms. Since at that time there was a lot of anxiety amongst the patients, therefore this spreadsheet also included mental and emotional states of patients to record associated anxiety or fear. The prescriptions were based on the individualization of symptoms. The spreadsheet also contained fields of detailed follow-ups and outcomes after 1 week of treatment. The confidentiality of all patients were maintained by using registration number instead of names. Then follow-up was done daily with till the complete resolution of symptoms or up to a week. Patients who were in home isolation were followed telephonically every day, and each follow-up, the patient was asked about any change in their symptom intensity and overall well-being. And this was assessed on the outcome in relation to impact of daily living, that is Ordinal scale, which ranges from -4 to +4. Apart from this, regular online meetings with all the doctors were organized to ensure the quality of data collection. The data was regularly monitored and cleaned, and any issues related to outliers, misreported, or missing data, etc., were quickly resolved. This was done to ensure consistency in data and maintain the good quality of cases and reduce bias. As we know, prognostic factor research is an important channel. It is a challenge in establishing causality between medicine and improved health, as the cure may be due to the effect of the prescribed homeopathic medicine or other confounding factors such as spontaneous or natural recovery or placebo effect. As we have seen in first wave of the COVID, that the patients were, mild cases were recovering on their own, even without any medication. Therefore, we included only those cases with a reported outcome of Oridal +3 or +4 and within 7 days of starting homeopathic treatment in both chief complaints and general well-being. And also those cases where the improvement began within a few hours of starting homeopathic treatment. 24 hours from the start of treatment was considered as cut-off time. And in cases where the continuing improvement after repeated doses of selected remedy was there. After data collection on spreadsheet was complete, each of the above cases were further reviewed using the domains of modified Eranjo criteria for assessing causal relation of clinical outcomes. 4 domains of Eranjo criteria were used, domain 1, 2, 5 and 10, which included for domain 1 was there an improvement in the main symptom or condition for which homeopathic medicine was prescribed. Second, did the clinical improvement occur within a plausible time frame relative to the drug intake? The 5, did overall well-being improve? And the last, did repeat dosing create similar clinical improvement? Then some cases were excluded. We screened a total of 327 cases were given treatment. Cases with inadequate information or where causality could not be established were excluded from the analysis. Also, mild to moderate cases are known to improve spontaneously in 10 to 14 days. Therefore, the cutoff time for our assessment was set as 7 days. So, in a total, 116 cases were excluded from analysis, 29 cases as they were inconclusive and unconfirmed RT-PCR report, 20 cases had inadequate follow-up or dropped out, 16 cases reported less than 50% improvement in 7 days, first 7 days. 7 cases were asymptomatic and 42 cases where causality could not be established due to any of the following reasons. Whether they were prescribed to more than one medicine or they were not given sufficient doses or improvement started after 24 hours. So in total, 211 cases met the selection criteria and were considered for analysis. In statistical methods, prognostic factor analysis is based on calculation of likelihood ratio to improve reliability of prescriptions or future studies. And it is expressed in statistical formula known as Bayes' theorem. And target population is population in which medicine has curative effect. LR of a symptom indicates a change in chance of curative action of that medicine when that symptom is present in patient. If LR is more than 1, it implies that the chance that the medicine will be effective increases if that symptom is present. Higher the LR, more strongly the medicine is indicated for that symptom. Then results, 327 patients with COVID-19 were treated with adjunct homeopathic remedies. Majority were in 18 to 60 years group. 298 cases were confirmed RT-PCR positive. 244 patients had history of contact with confirmed COVID-19 cases. 296 patients had mild diseases. 258 patients were prescribed a single remedy. And RT-PCR testing was done after treatment in 35 cases. In many cases, RT-PCR test was not done because at that time the protocol was to discharge the patient after 10 days without testing. These are the results. Most common complaints are fatigue, sore throat, dry cough, myalgia, fever, dry mouth, and throat, increased thirst. 27 medicines in varying potencies were prescribed, usually starting from 30 C. Medicines were repeated as per need of individual case, usually 3 to 4 times daily. In some cases, they were repeated more frequently. Arsenic album and bryonia were prescribed in 67 cases each. Gelsemium was prescribed in 19 cases and pulsatilla in 13 cases. Some lesser known medicines such as magnesium mure and Viathia also showed good response, though the number of cases are very low. LR was calculated for frequently occurring symptoms of 4 most frequently prescribed medicines. LR more than 1 indicates there is an increased chance that a medicine will be effective if certain symptom is present. By calculating LR, a comparative could be drawn symptom-wise between these 4 remedies for COVID-19 cases. This
Dr.
was the data which was collected for 4 medicines: arsenic, bryonia, gelsemium, and pulsatilla.
Dr. Gupta, could you please summarize, ma'am?
Yes, yes. So arsenic album showed meaningful LR for running nose and anxiety, bryonia for dry cough, constipation, dryness of mouth and throat, and increased thirst. This should be pulsatilla. This is wrongly read. Pulsatilla showed. This is something wrongly mentioned here. To conclude, homeopathic medicines have shown encouraging results in COVID cases. Prescribing indications of arsenic album, bryonia, gelsemium, pulsatilla have been identified using prognostic factor research. This information will be useful for designing RCTs and more accurate homeopathic prescribing to COVID-19 patients in future RCTs. Majority of COVID-19 cases presented with mild symptoms and recover with general care. Relevant selection criteria followed to rule out bias. This database of such cases can be attributed to causes other than prescribed homeopathic medicines. So bias cannot be completely ruled out. The bias of this study, related to this study will be discussed by my colleague Dr. Anjali Miglani in the next presentation. Thank you for this patient listening.
Thank you, Dr. Mehta. Pity that we don't have more time. And Dr. Anjali will tell us more about quality, so we have a complete picture of what is happening by the Ayush people and, well, high quality improvement of the homeopathic data collection. Thank you very much.
Thank you, sir.
Dr. Mehta, and thank you, Dr. Lex Rattan. Next, I would like to invite Dr. Anjali Miglani. Dr. Anjali is working as Chief Medical Officer, NFSD, with the Directorate of Ayush, Government of NCT of Delhi. She would be presenting Impact of Bias in Data Collection of COVID-19 Cases. Over to you, Dr. Anjali.
Thank you, Dr. Cheshta. Is my screen visible?
Yes, ma'am, it's clearly visible.
Thank you. At the outset, I would like to thank Dr. Meeta Gupta because she is my colleague and she has actually set up the tone for me so that I can take the work forward. Thank you, Dr. Meeta. I will be talking on the impact of bias in data collection on COVID-19 cases. This is a published study. It has already been published in Homeopathy Journal. Before we go forward, I just want to touch on this subject. What is bias? Actually, it is a particular tendency, trend, or inclination, or an opinion, especially that is preconceived and unreasoned. Bias can be unconscious or conscious. Unconscious bias can be easily activated, and it is generally unknowingly done. And it is very risky because what it does is it makes us as healthcare providers biased. And if it is unrecognized and unmanaged, it can be potentially harmful for our patients as well. So to recognize bias is very important. Just minimize this. Okay. Now we all know that homeopathy is an experience-driven method based on the observations of our practitioners. Therefore, these practitioners should be aware of all possible biases in their observations. This requires a great scientific attitude and a critical appraisal of their observations. Like, how valid is our observation that this patient's symptoms actually indicate that medicine? And are the symptoms really there, or does our observation deceive us? Presence of bias in a study restricts the generalizability and external validity of that study. So we analyze this data set qualitatively to detect any possible biases. And this was our objective also.
to explore the reasons for bias and their effect on the data, and to make recommendations to avoid such biases for the future. This is how we went about it. First, we took the ethical approval to do the study. This study actually was done in the first wave only. When we got encouraging results from the first study, which Dr. Meeta ma'am has already discussed, then we thought that it is a very good opportunity and let us collect more data and move forward. So when the ethical committee approval came, we started registering our patients. We targeted only those patients who were confirmed cases, whether by RAT or by RT-PCR test, and who had given us informed consent, which was a verbal consent at that time. Then we started prescribing medicines to them. Our doctors were free to prescribe whatever medicine they felt was correct for that particular case, depending upon individualization or totality of symptoms, as the case may be. The data was being fed daily on Excel sheet, which contained 71 fields. This sheet actually had symptoms of COVID. This sheet also had symptoms which were important from homeopathic prescription point of view, like the mental symptoms, the physical generals. And also there were few fields which were free fields, additional fields which we had provided, so that any doctor wants to give any particular information about any particular case can add it in that, so that the data is very well saved. Then we did the statistical analysis. Thereafter, these results I am sharing with you. It was a prospective open label observational study conducted from April to December. That was for 9 months. It was conducted at 2 COVID health centers, that is Guru Tegh Bahadur Hospital and Satyavadi Raja Harishchandra Hospital, both in Delhi, India. The cases were confirmed mild to moderate cases. The data collection was done on custom-made Excel sheet, and follow-up was done daily until complete resolution of symptoms or up to a week. In few cases, we even asked the patient how he or she is feeling after 6 to 8 hours of starting our treatment. The Oradel scale was used for patient assessment at each follow-up. Only those cases which had achieved Oradel +2 or more were considered. Improvement starting within few hours of starting homeopathic treatment, and the Oradel scale outcome should be achieved within 7 days of starting homeopathic treatment. If not, those cases were rejected. Out of 1889 cases collected, 1445 cases were analyzed and 444 cases were excluded from the study because 23 cases were asymptomatic, so we couldn't do prognostic factor research on them since there were no symptoms, so it is not possible to analyze those cases. 134 cases were duplicated entries. Actually, what happened once the patients were admitted, they were assigned another number, so somehow or other the earlier numbers got misplaced and the entry was done again. So when we checked the whole data completely again, we realized that they are the same patients. So we had to delete those cases as well. And in 287 cases, 2 or more medicines were prescribed simultaneously. In those cases, it actually becomes very difficult to assign causality. Which medicine actually helped in that particular case is very difficult to say. So those cases were also excluded from the analysis. Bayesian analysis was used and likelihood ratio was calculated, as has already been told by Dr. Meeta. LR is prevalence of the symptom in the responding medicine population divided by that in the remainder of the population. The higher the LR, the better the chance that the medicine will work if that particular symptom is present. We calculated the likelihood ratio for 9 most frequently prescribed medicines in that data set. That was arsenic, brynia, gelsemium, pulsatilla, heper, magnesium muriaticum, phosphorus, nux vomica, and belladonna. And it was done for 28 symptoms. Further to it, we also actually calculated the variance of LRs of the medicines for each symptom, as well as the variance of LRs of the symptoms for each medicine. The reason for this, I'll just explain you in further slides. The symptoms assessed in this project were mostly common ones. So it is presumed that in such cases, a moderate LR less than 5 should do the deal. However, we got actually outliner values in this data set, which I'll discuss with you later. So we assigned that wherever the LR value is more than 5, they were considered as outliner values. These are the medicines which have been prescribed. The most frequently prescribed medicine in this data set was brynia, given to 514 cases, followed by arsenic, gelsemium, hepersulf, Belladonna and pulsatilla were given in 60 cases. Each magnesium muriaticum in 47, phosphorus in 46, and nux vomica in 19 cases. This is the likelihood ratio. See, as you can see, the beauty of LR is that it actually tells you the medicine which will act the most in a particular data set in a comparative manner also. Like in this case, you can see for the symptom cough, if I compare all these remedies, the LR of Brynia is the highest. It is touching 2. Similarly, if I have a patient of COVID-19 complaining of, say, fatigue, myalgia, and headache, then perhaps gelsemium will act the best. Similarly, if I see phosphorus will act better in cases which have dyspnea as well as productive cough. Here you can also see that there is another medicine which has a very good LR almost touching 4, that is pulsatilla. It is also very good for productive cough. But when I compare the symptom dyspnea, the likelihood ratio is less than 1. So this helps me to differentiate the two medicines as well. Like if it is a case of productive cough with dyspnea, then phosphorus is likely to be more indicated. But once we did the analysis, we found that we are getting outliner values as well. Like for this symptom loss of taste and smell, LR is very high. It is in this graph, I couldn't go higher, but when I'll discuss with you the data, in that case, it was somewhere around 12. That was for magnesia muriaticum. Similarly, when I see nux vomica for the symptom diarrhea, it is again higher than 6. If I see another symptom, say, here it is, again, thirst decreased. For pulsatilla, again higher than 6. So as we moved forwards and we saw the results, we realized that there is something wrong with this data because see, we are getting outliner values. Here for the symptom chill, very high. Again, if I move forward, anxiety, very high. So that was the reason that we calculated the variance to understand how far is this data spread, how far it is from the mean. And this is what we got. When we calculated the variance, see, for the symptom loss of taste and smell, the variance is very high. It is 15.946. This is basically because of the reason, if I see all the LRs of all the medicines, this particular medicine has likelihood ratio of 12.91, which is very high. It is an outliner. While all other medicines, if you see, it is in the range of 4, highest being phosphorus 3.83. Similarly here, for the symptom chill and hypersulf, it is again a very high outliner value, 7.28. The reason for us getting a very high variance. If I compare the symptoms only for hyper, if I see the variance is very high, 14.05. It was actually because of two symptoms in hyper, that was productive cough as well as chill, because they both had very high LR. So in that case, the variance increased. For magnesium muriaticum also, it is a high variance. Why? Because of the symptom loss of taste and smell. The LR was very high. In this table, you can also see another peculiar thing. See the empty spaces, blanks. This shows, these blanks actually tell us, if I go back here also, blanks. Again, in which population? More in hyper and magnesium muriaticum. If you see in pulsatilla, the blanks are comparatively less. There's no blank here, no blank in arsenic, belladonna, and brynia. In these medicine populations, we are getting more blanks. This means either this particular symptom was not present in that population for that medicine, or it was not checked, which is very important for us to learn. These were the outliner symptoms for these particular medicines. For nux vomica, it was mostly the abdominal symptoms like flatulence, diarrhea, abdominal pain. Magnesium muriaticum, one symptom, single symptom, loss of taste and smell. When we did the analysis, we found that the prevalence of this symptom in the data set was actually just 10.2. But for magnesium muriaticum population, it was more than 97%. It was 97.8%. That is very high. And this medicine was mostly prescribed by one single doctor. And see the blanks. There is no other prescribing symptom to be told. So we understood that there is bias in this data. It was confirmation bias, lowering of symptom threshold, keynote prescribing, and insufficient checking of symptoms were the most important causes for this bias. Confirmation bias, as we all know, when the symptoms that match the preferred medicine or disease are more easily recognized by the physician. While doing case taking over a period of time, we tend to think that this particular patient is looking more like pulsatilla. And then even if the patient says his thirst is uh, a little less, I'll jump on that symptom and I'll take him thirstlessness, because then what I'll do, I'll lower the threshold for taking that symptom as an important symptom, even though its intensity was low. So that causes bias. Then keynote prescribing, just prescribing on one or two symptoms is keynote prescribing, like we've seen cases of hypersulfmagnesium ureatic. So the take-home message is that careful identification of biases is very necessary. During the first consultation in prognostic factor research study, a predefined set of symptoms should be checked apart from the context of the patient, even if the practitioner has already recognized the indicated medicine. In this particular study, we had already circulated the Excel sheet in advance, well in advance, initially only. But since the doctors were invariably biased, they didn't check all the symptoms. So this resulted in this. I won't say that it was intentional, because what happens is, because there's a lot of workload, the time to have a patient doctor conversation is very less. And being COVID-19, the scene was pretty scary at that time for doctors as well. So those might be the reasons why this happened. And definitely, because when you have a less time, you tend to think, okay, that this case is looking like belladonna, and already I have seen my cases of belladonna improving, then why not give belladonna? So perhaps that was the reason. But when we do prognostic factor research study, it actually becomes very important for us that all the symptoms are checked, because then otherwise we won't be able to understand the prevalence of that symptom in a particular population, and then it becomes difficult. So that is all a summation. So remedial steps such as training of doctors, regular monitoring of data, checking of all predefined symptoms, and a multi-centric data collection are very important to mitigate bias. The more doctors we get to pool in, the bias gets decreased. So that is all from my side. What the way forward is that prognostic factor research in observational studies is an important technique for the analysis of cohorts of real-world care settings. Such studies provide prior experience, which is very necessary for planning an RCT. Also, it may help to build a consensus among homeopathic practitioners worldwide if you all come together and share our experiences. Considering that many countries are still affected by this enigmatic virus, and there seems to be little respite from this pandemic in near future.
Thank you very much.
Like to thank my co-authors for this, and special thanks to Dr. Manchanda sir and Dr. Lexstratton sir for mentoring us.
Thank you very much, Anjali. I think we may add to this project that it was a very open-minded attitude from the doctors participating, and I think that's a very strong point, because we are not used to data collection, and openness about your bias is an essential point in data collection, I think. Thank you very much.
Thank you, sir.
Thank you, Dr. Anjali, and thank you, Dr. Lexstratton. Now I would request my co-moderator, Dr. Thankraj, to take the session forward.
Thank you, Dr. Cheshta. With the permission of the chair, I would like to welcome our next speaker of the session, Dr. Philippa Filbert. Dr. Philippa Filbert is postdoctoral researcher at Queen Mary University of London. And the title for her presentation today is Service Evaluation of Treatment by Homeopaths for Long COVID. Over to you, Dr.
Can you see my screen?
Yes, doctor.
Thank you. So thank you very much for this invitation. I would just like to start by saying that initially my presentation was put in the education section, and I only discovered 2 days ago that actually I was being put in the COVID section. So I have adjusted my slides accordingly, but if there is a slight educational bent to this, that is the reason. I'm going to describe to you today a service evaluation that we've been undertaking, which we've called the Long COVID Pod Project. The idea behind pod projects where's my slide? Here we are. They were set up because we in the UK, as you probably know, have a parlous situation where homeopathy is concerned. We are consistently under attack. We have very little support, and there is very little, there is no research going on. And we feel that one of the ways in which we can start to reverse the situation is simply by describing what we do, by getting our patients' voices, asking our patients, because they are our best advocates. And patients are still coming to see homeopaths in the UK privately, despite having free National Health Service treatment. So the idea of pod projects was to gather groups of homeopaths together to collectively gather data on particular conditions. So they would work together with similar treatment interests. They would support each other with remedies and patient management. And they would ask their patients to regularly complete relevant questionnaires. And those that data would be recorded, and then those aggregated responses would describe treatment progress over time and would be able to make up service evaluations. And the hope is that this kind of structure can provide the basis for more systematic research going forward. So the first pod that got going was the long COVID pod. So long COVID, as you probably know, is it's symptoms of people who have had COVID, and they've had symptoms that have persisted for at least 12 weeks since having had the coronavirus. And what we're finding in the UK, that these debilitating symptoms are being observed in an estimated 1.6 of the population. Predominantly middle-aged females seem to be suffering, and the common symptoms of those who have long COVID are fatigue, post-exertion malaise, cognitive dysfunction, sleep problems, emotional and mood changes, headaches, and musculoskeletal complaints. So in the UK, conventional treatment is mostly supportive rehabilitation, with each particular symptom managed with a relevant drug or therapy. And what our patients are saying is that it doesn't help them at all. And what we were finding anecdotally was that homeopathic treatment, which was looking holistically at patients, was being effective. So we set it up because we were already supporting NHS, that's our National Health Service workers, in the first wave of COVID. And we found a few of the NHS workers were continuing on with long COVID, and that we had very good results with them. So we decided this was something we needed to document more systematically. And this was in conjunction with Ainsworth's Homeopathic Pharmacy in the UK, who were providing free remedies for the NHS workers. The pod consisted of 10 homeopathic practitioners, of whom 9 were private and 1 was a National Health Service practitioner working in Scotland in the Glasgow NHS Integrative Medicine Hospital. And we started off by using an online database to record symptoms. We were full of hope that this database, which really provided the initiative for us to start this data collection, would be a great resource for large-scale data collection. However, unfortunately, during the first wave, the person who had made the system and developed it over a decade just disappeared. The system became increasingly unworkable. We became unable to ask our patients to use it. And we then had to resort to paper MyMops or paper on sending emails and inputting data by hand. So this was extremely unfortunate. We found that most of the people who came were female. We only had 2 males, and the average age was 48.5. And almost all of them had suffered from long COVID for between 3 months and a year, and they were all vaccinated. and they were all already under conventional care. We're now beginning to see more patients who've had it for longer, because obviously they're then still not getting better, and they've suffered for longer and they're still turning to us. So the outcome that we used was MyMop, which I imagine you're familiar with. It allows the patient to select which symptom bothers them most, and then you measure it on a Likert scale. And we collected 3 MyMops at the baseline when they first came to see us, and then at the first consultation follow-up, and then at the second follow-up. And these were the kind of symptoms that were bothering our patients. The majority, the biggest problem was fatigue, chronic, long, heavy fatigue, but breathlessness, memory fog, weakness, loss of taste and smell, these were also common symptoms that continued to plague our patients. So how did our patients get on? How did they get on with this treatment? We've gathered the data for 36 long COVID patients so far. They have completed their first MyMop, and then we have 29 MyMops for the second MyMop, which was 4 to 6 weeks later, the follow-up. And then we have 11 patients so far who have completed 3 MyMops, which is after approximately 10 to 12 weeks. So as you can see here, this is for the 29 patients who have at least 2 MyMops. And the blue is the first consultation, the orange is the second, and the gray is the third. So you can see that at an individual patient level, we're seeing really good improvements. Usually by the time they have their third consultation, they're really doing well. What we find is that those with serious comorbidities, such as fibromyalgia, are the ones that are finding it more difficult to improve. But we're still seeing improvements with those patients. So how does that convert to overall? So if you have just your 2 MyMops, you see a difference between MyMop 1 and MyMop 2 of a score change from 4.1 to 2.67, which equates to 37% improvement. That's just after your first consultation. And when you have 3 MyMops, and I'd like to remind you that that's only 11 patients that we can compare, these are the score changes. So after the first consultation, we were seeing 32.5% improvement. And then after the second consultation, we were seeing 50.5% improvement. So we're seeing very good improvements. And I must say that as the numbers are building, the percentages are not really changing. We're seeing sort of roughly around 33% and then roughly around 50% as we add more patients. So what was the homeopathic treatment? What were the remedies that we were using? So as I mentioned, we're working in conjunction with the Ainsworth Pharmacy, and they developed nosodes from coronavirus as the different variants were appearing. And the frontline treatment was the start treatment, which we gave, was the relevant nosode. So it started off being JPV. These are the initials of the patients, by the way, who suffered from acute COVID and from which the samples were taken, the sputum samples. And then we moved on, which JPV represented the alpha variant, LOU represented the beta variant, and OW the delta variant. I don't think we have an Omicron variant yet. And so before we even saw the patients, they were sent the relevant nosode to take for a month, and they completed their MyMop form. So the first MyMop result at the first follow-up actually represented the effectiveness of these nosodes. At that moment, we then prescribed additional individualized homeopathic remedies to kind of mop up what was left. But what we saw when we first at the first consultation was that there had already been quite a significant improvement in energy. The nosodes seemed to increase the vitality of the patients who'd taken it. The individualized follow-up remedies that we used were these. These are carcinosin, cactus, lachesis, medarhinum, natrum mur, nux vomica, phosphorus, thilia, and sepia, and a few other smaller ones, but those were the main remedies that we used. So to sum up, we are finding that homeopathic treatment is associated with patient-rated improvements in their self-identified symptoms. Obviously, this is just a descriptive study, so we can't apply any causality at this stage. So patients described improvements of 33% after taking COVID nosodes, and then the addition of individualized remedies was associated with further improvements, leading to about 50% improvements after 3 months, according to the patients. So in conclusion, I'd like to emphasize that having an online database would have been so much easier. I would like to say that, service evaluations are a really good way of describing patients' experiences with homeopathy. But the biggest obstacle that we encountered was actually reminding homeopaths to collect the data. They're not in the UK habitualized to doing this, and it was a lot of work to remind them and to get them to do so. We're pleased to say that MIMOP is increasingly recognized as a valid and useful tool, and is increasingly used in our National Health Service. And as a result of this, future more robust studies are definitely indicated. And I'm pleased to say that the Homeopathy International Hint are currently fundraising in order to try to enable a more robust study to take place. I'd like to thank LMHI for the opportunity to present this small service evaluation, and Ainsworth Pharmacy, who have provided the remedies, and also Dr. Claire Relton, with whom I work, and who conceived the idea of the data collection project initially. Thank you very much indeed.
Thank you, Philippa. I think there's room for one question, maybe.
Okay.
I have one question. It seems to me that the memory fog is more in long COVID than acute COVID. Is that right?
That certainly seems to be the experience, yes.
Okay.
I would agree, yeah.
Might be an interesting thing. Any other questions? Okay, then we can move on. Thank you, Philippa.
Thank you, Dr. Philippa, and thank you, Dr. Extrapan. Now let me invite our next speaker to the session, Dr. Vipin Chattani. Dr. Vipin Chattani is Associate Professor in the Department of Organ Medicine, Nehru Homeopathy Medical College and Hospital, New Delhi. The title of his today's presentation is Clinical Characteristics and Remedy Profiles of Patients with COVID-19, a retrospective cohort study. Over to you, Dr. Vipin.
Thank you, Dr. Thankraj. A very good evening to the respected chair, dignitaries, delegates, and colleagues across the globe. Before I take up my session, my topic, which is on clinical characteristics and remedy profile of patients with COVID-19, a retrospective cohort study, I would just like to tell you, give a brief sketch of the period in which this study was undertaken. This study was basically undertaken during the first wave of COVID, that is somewhere around May and June 2020, when the information about COVID and its clinical characteristics were hard to come by. They were just trickling in the medical literature. And it was also the time that there was a lot of research going on about the repurposed drugs, be it from conventional medicine point of view or be it from the homeopathic point of view. The information about the clinical characteristics as well as the repurposed drugs were fairly limited. And in fact, if we look from the homeopathic perspective, there were just 2 studies which were majorly available to us. One was the Hong Kong study and one was the study in Italy, to understand the clinical characteristics and thereby try to find out the remedy profile of the patients of COVID. So in this background, I'll go ahead with my presentation. This was a collaborative study that we had undertaken at Nehru Homeopathic Medical College and Hospital, which is under Government of NCT of Delhi. And in this study, we had collaborated with the Center for Computational Biology and Bioinformatics, Amity Institute, because they did the data analysis for us, and they also provided backend support in the curating of data, which was available during the study. And primarily also because this study was during the study there were certain guidelines of the government which were applicable on us, whereby we had to mandatorily give conventional medicine along with the homeopathic medicine. So we had taken help of allopathic physicians from another government hospital which were helping us in the treatment of patients. This study was authored by, among many, there were a lot of physicians of government sector which are involved in the study, as it's shown in the slide. So just to begin with the background of the study, we all know that COVID pandemic had challenged the healthcare sector because there was no proven therapy available at that time. And there was also a need was felt for a prudent strategy to integrate the complementary medicine with conventional medicine to combat the pandemic. Therefore, the need was to explore the potential role of homeopathic treatment in COVID-19 and characterize the data of COVID-19 patients as the first step to identify the effective remedies for the as genus epidemicus. And subsequently, the next step would have been to test these very remedies on the scale of randomized controlled trials. So therefore, the primary objective was to identify the clinical presentation of laboratory confirmed COVID-19 patients through a retrospective cohort study and identify a group of indicated homeopathic remedies based on their symptomatological profile. And the secondary objective, as I already said, it was to compare the collected data with those from similar studies in order to form a design for a suitable RCT. As is the norm, the ethical clearance from Institutional Ethics Committee was obtained for undertaking this retrospective analysis of patients which were admitted in our hospital. One more thing, because there was a lot of collaborative studies which were going under the aegis of LMHI for data collection. So as a part of the ethical clearance, we had also taken the clearance for sharing the data with international organizations, specifically LMHI, so that we could have a consolidated data for understanding the clinical profile of COVID. Just to give you a brief overview of the study design, as I said, this was a study which was undertaken at Nehru Homeopathic Medical College Hospital, Defense College, New Delhi. This hospital was designated by the government of National Capital Territory of Delhi as a designated COVID health center, because around that time we had three category of hospitals which were working under government of NCT of Delhi. One was a COVID care center, which was for mild cases, COVID health center, which was taking care of mild and the moderate cases, and COVID hospitals, which were just taking care of the severe cases. So our hospital was designated by government as a COVID health center for catering to the mild and moderate cases of COVID. The method that we adopted during the study was a retrospective analysis of COVID-19 patients. This was kind of a cohort that we formed who were admitted to in this hospital. As I already said, this study was between May and June 2020. So they were admitted in hospital between April 29 to June 17, 2020. The patients were grouped into mild and moderate categories of disease. Their symptomatological profiles were analyzed to identify the indicated homeopathic medicines. Since this study was only taken up at Nehru Hospital, so this was a unicentric study, and this was more of a observational descriptive study because we did not have a parallel arm to compare the effect of homeopathic medicines, which are already being given as an adjuvant to conventional treatment. So this was a unicentric observation study, which is more of a descriptive type rather than an interventional study. The inclusion criteria that we took for the study was RT-PCR confirmed COVID patients who were willing to provide informed consent to share their data, demographic as well as clinical, and mild and moderate category of COVID-19 patients. The exclusion was that those patients who had uncontrolled comorbidities, specifically diabetes and hypertension, they were excluded from the study. Those who were either on anti-tumor therapy or on immunosuppressant medicines, they were excluded from the study, and so also the severe category of COVID-19 patients. We had considered a sample of 196 patients of mild to moderate disease, of which majority were 178 patients had mild symptoms and 18 patients had moderate symptoms. And that is why one of the reasons why interventional analysis was also not done, because majority of the patients were mild symptoms, which had a tendency of self-limiting course. The data collection was done on a standardized case record form, which is used for case taking. The symptoms of infection were identified and severity of disease was assessed in this form. This form had we had included the clinical manifestations as were given by the WHO case format in this particular form. So as for the purpose of standardization of clinical symptoms. The study variables which we studied were the demographic details and the clinical symptoms of COVID-19 patients. The data analysis, as far as data analysis, the data analysis was done on case record forms of all the admitted COVID-19 positive patients, and the data analysis was done retrospectively. The patients having common and characteristic symptoms were identified. As is the norm with any form of research, we had taken the informed consent, we had ensured the anonymity of data, the confidentiality was maintained, data recording was done on prescribed formats for the purpose of demographic data, clinical characteristics, relevant laboratory data, treatment programs, and outcome measures. As I've already clarified, with regard to the treatment program and outcome measures, because there was no parallel arm to identify the effect of efficacy of homeopathic medicine, so we had just done the observational part of demographic data and clinical characteristics. The relevant information was periodically reviewed, and the data was curated at regular intervals for eliminating observation bias. Now, coming to the results of the study, the one important finding that we observed as a part of the demographics of the study was that in the mild category of COVID-19 patients, we were getting fairly younger age group. Like as the data shows, the standard deviation SG was around 38.6 years. While in the moderate category, the older patients, the elderlies were coming to us more into the moderate category, with the standard median being 66 years of age. So this is showing the mean for the moderate was around 38 years of age, and mean for the moderate cases was around 66 years of age. So this was important finding. Another important finding was there was male preponderance of cases, with majority of patients being male. Then when we come to the clinical data, which was analyzed with regards to the symptoms of the patients, we found that majority had fever, and specifically low-grade fever, the cough, and more specifically dry cough, and sore throat, as well as headache. These were the important symptoms in their frequency of appearance. As I said, fever was predominantly low-grade, with predominance of heat stage. So we were getting more patients with low-grade fever with heat stage and dry cough. Without going into the research part of the interventional of the homeopathic intervention, I'll just elaborate upon the remedies used during the study. The most commonly prescribed remedies were Bryonia alba, Arsenical, Pulsatilla, Nux vomica, Rus toxicodendron, and Gilsemium. And primarily, the majority of the patients were prescribed in 30 potency. In fact, 120 patients of the 196 patients were given medicines in 30C potency. Because we were in a very early phase of understanding the disease, as well as understanding the repertorial chart of the medicines with respect to COVID, we initiated a kind of a very baseline form of repertory for COVID, in which what we did was, according to the frequency of appearance of symptoms in a given drug, we formed a mini repertory of that particular drug. So what we did was, the patient's symptoms and signs were extracted from the case record forms. They were converted into rubrics using the repertory, and the prescribing indications for we kind of formed a mini repertory of COVID for 6 drugs on the basis of frequency of appearance of the symptoms. For example, just to show you one example, we have mentioned the example of Bryonia, in which we found the most common symptom of Bryonia, which was appearing in COVID-19 patients, was a slow manifestation, dry cough during fever, thirst for large quantities, cold water, constipation, etc. So these were the kind of according to the frequency of appearance of symptoms, we had formed a kind of a mini repertory for COVID patients with respect to each remedy, which was prescribed in the research study. One important takeaway from this study was that the remedy profiles which majorly emerged during the study were of Arsenical, Bryonia, Pulsatilla, Nux vomica, Rus tox, and Gilsemium. And it was also found that these remedies could be used for further studies, and to be taken as RCTs. When we compared with the data sets, because as I already said, the information with regards to the global data was very limited. So we compared the data from conventional medicine point of view. We took the data from the Chinese studies, some of the studies done in the hospitals in China, and from the point of homeopathic, we compared the data of the study of Italy and Hong Kong. And what we found was that among the symptoms which were the clinical manifestations of COVID, which were available for the study in our setup, the only difference was that we found a greater prevalence of sore throat in our study, vis-a-vis the symptoms of research found in the study in China. And when we compared the information available from the study of Hong Kong and Italy, we found that no doubt bryonia, arsenic, and gelsemium were already the top grade remedies which were appearing in their studies. But we found that remedies like naxomica and dostoxicodendron are also important in the study which was conducted at NHMC. As I will side by side, I've already explained that this was more of a descriptive study because the conventional drugs were given along with the homeopathic medicines. So interventional outcome assessment was not ascertained because as for the simple reason that would have involved the prescribing bias. There was no control arm to assess the effectiveness of homeopathic medicines. And being a primary healthcare sector, we had very limited laboratory resources and no radiological support to assess the prognosis and the outcome measures of the disease. So what were the salient features? We all know we've been studying as a part of genus epidemicus. The first step, as laid down by Hahnemann and Organon, is to identify the collective picture of the disease. So this was the step that this study intended to take up. The first, as I said, it was to identify the potential effectiveness of homeopathy by delineating the clinical presentation of the pandemic. And based on the symptomatological profile, 6 homeopathic medicines were shortlisted for further evaluation. And the study highlighted the importance of critical evaluation of data and data curating to shortlist the homeopathic medicines, which would serve as stepping stone for further studies for science, for systematic validation. And this study was published in the peer-reviewed journal Homeopathy. This was the team that we had. This study was conducted under the guidance of Dr. Manchanda, Dr. Anu Kapoor ma'am, who's the principal of the hospital. And this was a kind of as I already said, collaborative study between the Department of Ayush and the Center for Computational Biology of Amity Institute. So thanks a lot for your patient listening. That's it from me. Thanks a lot.
Thank you very much, Dr. Deepin. This is a very nice example of standardization of data collection, so we can compare the different data collection, which is one essential aspect of high quality data collection. Thank you very much. There might be one other question. Anyone? Okay, then we can move on to the next. Thank you.
Thank you. Thank you, sir.
Thank you, Dr. Lexterton, and thank you, Dr. Vipin, for that excellent presentation. Now, with the permission of the chair, let me call upon our last speaker of this session, Dr. Dipti Singh. Dr. Dipti Singh is the research officer at Central Council of Research in Homeopathy. The title of the presentation is Evaluation of Urgent Homeopathy Treatment in COVID-19 Hospitalized Patients in Gujarat State's Dedicated COVID Hospitals. A multicentric single-arm retrospective study. Over to you, Dr. Dipti.
Can you please let me know if my screen is visible properly?
Yes, Dr. Dipti.
Okay. Thank you so much. My warm regards to all the dignitaries and to the participants who are delegates of the conference. Today we are having so much evidences and studies about COVID. So I'm so glad that I am also able to share some of my observations, which we have conducted at CCRH. So we got an opportunity to evaluate the data which was gathered by the homeopathic medical officers of Gujarat, where adjuvant homeopathy was given to the COVID-19 patients. So since we will be highlighting about the experiences of adjuvant homeopathy in Gujarat. So to give a background about what was the situation, this the first wave of COVID in the state of Gujarat in India. So the Gujarat got its first two cases in the month of March, the 27th March, where two cases were reported to be COVID positive with a history of travel, international travel. So what we saw in state of Gujarat, the cases were doubling within 3 to 4 days in the first half of the April month, that is in 2020, which improved to nearly 28 days by mid of the June. But it was much above the national average of nearly 17 days. So, with the lowest cases which was reported in Gujarat was on 17th February, and again it peaked to the second wave. The state-wise recovery and death of Gujarat. Gujarat was one of the majorly affected state in India. During that time in June, a WHO situation update report published on 14th June indicated that Gujarat was having 69% recovery rate, which was compared to 50% total recovery rate of India. The mortality was also high, that is 6.3%, which was compared to 2.9% in total during the month of June 2020. So, considering that it was quite majorly hit by the first wave in COVID pandemic, the state government of Gujarat took comprehensive measures. So, based upon a report by IIM Ahmedabad, where the responses and preparedness of Gujarat government was highlighted. Included that there were multi levels of measures that were taken, starting from airport screening, spreading of information and education, contact tracing, testing. A district level task force was also constituted, besides other COVID-19 related support measures. The important was the manpower augmentation and training, which included training of the Ayush professionals, including the homeopathic medical officers and all the under the Ayush COVID warrior program of the government. And Gujarat also established the dedicated COVID-19 hospitals and care centers. Under that, the homeopathic medical officers who were trained and they were deputed to the dedicated COVID hospital setups, the civil hospitals where all the patients were being admitted during that time. So we got that opportunity that through the state government Ayush department, the treatment was allowed. Adjuvant homeopathic treatment was allowed in the COVID-19 patients, and in an integrated manner along with the standard treatment that was given to the patients. CCRH got the opportunity that they were able to get some data for the retrospective analysis, so that we can see how what homeopathy if homeopathy has any role to it, and what data we can we try to do some analysis out of it, what best possible thing which we can get out of the data, because it was a huge data. So and the homeopathic medical officers initially they were not taking the cases as per uniform format, so they were advised that they take the data on a an online training and orientation was given to the doctors that they should at least capture the data in a uniform way, and so that the any meaningful outcome can be taken out of them, so that they did. And finally we got the data of a large number of cases, more than 6,000 during this period, which I am reporting here, is that after the month of July till December 2020. So what the objective of this evaluation is that we want to evaluate that if there is any role of adjuvant homeopathy in management of COVID-19 patients, the time to clinical improvement of symptoms, was there any effect on that? How many cases had any worsening? What was the death rate in those cases which received the adjuvant homeopathy? And how many is, as it was a very pragmatic setup, all the cases were given, so there was no exclusion criteria of sorts where comorbidities or anything were excluded. So, how the response was in patients who were comorbid and were considered as high risk group. Uh, how many cases progress to the severe category where they have to take any support of oxygen or ventilator support, etc. And eventually what medicines were found to be most commonly given and have any role to play. Taking into these objectives, we collected the reviewed and collected the data from the hospitalized patient who were having COVID-19, and they were given standard treatment. Along with that, the homeopathic medical officer gave the adjuvant homeopathy in the dedicated state government dedicated COVID hospitals and also the COVID care clinic. The standardized Excel sheet and homeopathic COVID case records, which were developed as a short form where they just have to click, tick or cross about the relevant information, because considering that the comprehensive case taking was not possible for the cases, considering all the physical limitations of wearing the PPE kits and all. Case record form was provided so that they can just collect the information, and they eventually entered the data on Excel sheets, which was shared with the council. The information collected was mainly about the demographic information, the clinical symptoms, and the homeopathic management, and what was the outcome. The study population was like of all ages, both the genders who were having the confirmed diagnosis based on the state government guidelines. If they were having an RT-PCR or a rapid antigen test and were admitted in the COVID wards. And those cases were taken, and we excluded the cases where we were not having sufficient information pertaining to their discharge date or the COVID status, were this like in COVID care centers. Patient who were suspected or were in contact also were admitted. So in that cases where we saw some underreporting, we excluded from the analysis part. So we also took the consent from the patients, like you will be provided. We explained that you will be given an adjuvant homeopathy, and we will be collecting the data, which we may like to analyze later on. So all the patient provided consent, then only we had given them the adjuvant homeopathy. So from June 2020 to December 2020, the council received the Excel sheet and the scan cases together of more than 6,000 cases. But they were like again filtered and reviewed because of the limitations I have just told. And finally, the data of 2,581 cases was put to the analysis, and observations were made on that. So study site, the state of Gujarat, there are many districts in the state. So these were the centers which the data were found to be at par, so that we could analyze the data. These are the districts. We can see the Surat was also one of the majorly affected district. The cases which we have included in an analysis is one of the highest, along with Rajkot. And yes, Surat was a big district. Maximum cases we received from that, and there were 3 different sites, like civil hospital, Samras Surat Hospital, and the Smimar Surat, followed by Ahmedabad, that is capital of the state. Coming to the patient characteristics, while we observed what types of patients which we are having, so it was quite evident that there was a male preponderance of the cases, with a significantly higher percentage, like 70% male as compared to 30% females in the group. And the median age was 41, ranging from 29 to 53. That was the interquartile range. Minimum age was 11 months baby who was admitted along with the family members, and maximum age was 89 years. The presence of comorbidities were also present there. Out of the 2581 cases, around 500 cases were having some form of the pre-existing condition or a comorbidity. That is around 20% of the data. The common comorbid conditions in these hospitalized patients which received adjuvant homeopathy was hypertension, followed by diabetes and other conditions like COPD, asthma, thyroid disease, etc. So we can see the group was, it was like all sort of patients who got affected were able to, get this adjuvant homeopathy. Clinical category. So while putting the cases into the three categories, we use the guidelines which were issued at that time in June 2020 by our Ministry of Health and Family Welfare, describing the cases as asymptomatic, mild, moderate, and severe based upon their clinical condition. Like mild were there no evidence of breathlessness or hypoxia. Moderate had the presence of features of dyspnea, hypoxia, cough, fever, with the SpO2 between 90 to 94%, and likewise the severe category. So this is the breakup of the cases according to the categories which we are having. So out of total admissions, the maximum patients which we have in this set of patients is of under the mild category only, followed by some asymptomatic cases. We do have cases which were in moderate and in severe category. So we will see that the presenting symptoms are in line with what other clinical characterization studies have reported, that maximum was the weakness and fatigue that was found in 55% of the cases, followed by cough, mainly dry cough, and fever, headache, and likewise all other symptoms listed here in the graph. So that was the presenting some symptoms of the cases. So what one of the important outcome which I explained was the time to clinical improvement. So what we found that the median time to clinical improvement after taking the adjuvant homeopathy was found to be 5 days. That is, more than 80% patients were discharged by the 7th day of admission, subsequent to starting of the adjuvant homeopathy. There was some significant association found between the age of the patients and time to recovery. That means the nearly 1/3 of the cases got clinical improvement, which we consider as the discharge within 8 days in young adult age group, that was 20 to 39 years of age. Also, patients which were having comorbidities, those patients also were relieved and they were discharged within 7 days of take after thus they have started the adjuvant homeopathy. So the start of adjuvant homeopathy might not be on the day of admission or the day they were diagnosed. So there was that lag also. So we have taken the time when the homeopathy was starting and then when the patient was discharged. That was which we have calculated. So in the recovered patients, we can see the out of 2063 patients that were the recovery patients where outcome discharge was present, we have measured that. So the duration of relief was between 0 to 7 days, and recovered cases were assessed from the day of illness. That is this recovery of the patients which we have calculated from the day of illness. That is, we had the date from which the confirmation of adjuvant homeopathy was started. So more than half of the patients, around 1,300 out of the total recovered patients, were administered homeopathy within 0 to 2 days. There were some cases which were given homeopathy after that time also. So while we also try to analyze the probability of the time to event, here is the clinical improvement or recovery using the Kaplan-Meier method, and differences in time to clinical recovery due to the factors like age, sex, presence of comorbidities were compared using the log rank test, and we found out that they were all quite non-significant. The only significant association was found in the estimates where the recovery was found in the clinical category of the patient, that is the mild category only. So what we can observe out of here is that
Dr. Singh, you've utilized the question and answer time as well.
Okay.
So, summarize, yeah.
Okay, give me 2 minutes more. I'll just quickly jump through.
And we just have only 30 seconds more.
Okay. So we found that I'll just take to the last slide that as compared to the general population data of Gujarat, where recovery was of 9 days, here we found that there was our average was 5 days. So finally, the discussion point is that although there was limitation that we did not have a control group here, but yes, we can say that there was very less amount of mortalities. Out of these 2,581 cases, 3 deaths were reported, and the patients who were even having comorbidities did not progress into any kind of severity. That is only 2% cases reported any kind of worsening. So we have an observation that overall taking an adjuvant homeopathy is beneficial. So this can go for an integrated use of homeopathy for management of COVID-19 patients. Thank you so much, and I apologize for taking the extra time.
Thank you, Dr. Deepti Singh. Dr. Lexington, would you like to ask some questions to Dr. Deepti?
Yes, I have one question. It seems to me that there are many people excluded from data analysis, unless the fact that it was were hospitalized patients. Is there an explanation for that?
Yes, so that is a very major drawback here, because we lost upon the data of more than half of the cases, like it was more than 6,000. But again, we could not utilize, because the data was coming from different sources, and the quality of data capturing was not appropriate. So once we have any method where all the practitioners capture the data, they do not miss upon getting the important information, like we want to know when patient started taking medicine, when patient was discharged. So these things were missing. So underreporting is the major drawback here. That is the reason.
Okay, thank you. Well, there were several projects where we noticed that, well, homeopathic practitioners still have to learn how to collect data and do it in a proper fashion.
Yes.
Is there still another presentation?
No, Dr. Lexington, this was our last speaker.
Can I ask a question?
Yeah.
First of all,
Yes,
I wanted
please.
to say
Yes.
hello, Deepti. It's really lovely to see you again.
Hello, thank you so much. Lovely to see you.
And I was wondering why Gujarat had such problems with COVID. Do you have any hypothesis?
There is the reason which I have detailed in the manuscript, because Gujarat is a state having borders with many other states, and Gujarat is one of the state which was having large number of cases. There were many. It's not the on the topmost list, but the reason is that we had many bordering states, and initially there was lot of people who were coming from different state, having history of international travel. Besides other than this, there is no other significant association or cause related to the why the state was specific. Because COVID, we cannot say if it's related to any kind of particular weather or a demographic conditions. So we can just say the exposure and the measures could have been the reason behind the large number of cases.
Thank you.
Thank you.
Thank you very much. So I think my function is now to make some summary of this.
Yes, Dr. Lexington, please have the closing remarks.
Sorry, what did you say?
Dr. Lexington, I invite you for the concluding remarks. For the concluding remarks, please.
Okay, thank you. So we saw 6 presentations, and there were part of it was about improvement of homeopathic data collection, and part of it was about the place of homeopathy in COVID and also in long COVID. My impression is that there is a steep learning curve in this pandemic, where homeopathic doctors are realizing that there should be standardization in data collection, and that the quality of data collection is essential to go on. And I think it would be interesting to compare all the projects that have been done in this past 1.5 years, and to see if all this information can be used to standardize and improve more our treatment for long COVID. I hope that Philippa agrees on that. Well, this is what I want to say about this.
Thank you, Dr. Nextrecker.
Any more discussion points?
No, sir. No questions in the chat box.
Then we conclude that all was very clear. Thank you very much.
Can I have a submission over here? If
yes, Doctor.
If time allows, yeah. So I just I'm sorry I could not mention this during my presentation, and I'm just trying to steal some minutes here. This particular, just as Dr. Lex is mentioning, that this COVID pandemic has been a knocking at the door for all of us to reconsider the way we collect our data, and we have our own voice. We have to kind of record our data very effectively. But having said that, our limitation in our study, like where we had to enter the COVID wards, the ICUs with the full of COVID patients with practically no prior experience. And we had done a lot of study of therapeutics and literature and whatnot to say, because we were there to treat every patient individually, in an individualized manner. But having said that, it was practically not possible to, collect as many data as we would have wanted from those patients who are literally having the mask all the time on their, faces and can barely speak. So what we had to really rely on was the clinical parameters that were available in the reports or on the BiPAP screens, which helped us, just get started. And then once the patients were a little stable, we could have, more of individualizing symptoms from them. So that is actually also partially an answer to your question of why Viritum viridae scores the highest. It was just because purely on clinical indication, we just started with it because we could not really have the patients, patients were half of the mind whether we should go for this homeopathy treatment or not at this particular stage. And we did not want to really bother them with asking too many questions that individualizes them. So we were just, and all the patients literally had thirst because of that oxygen mask on them. So they feel very dry and all those things are there. So we had to literally start with a clinical medicine, which is very specific for most of the COVID patients, and then move on to more individualizing characteristics. So I think particularly this kind of experience, if we can get more, probably we'll be able to really figure out what is the symptomatic picture for homeopathy treatment in the severe patients, most probably. That was my submission.
Thank you, Harleen. This was indeed a once-in-a-century experience. And, it shows that it's essential that we have good communication platforms where we can exchange information. And if we standardize things more, then, it should be possible to exchange data that are essential within, I think, 2 months to improve treatments. That at least was our experience with the LMHI data collection project, that we could produce the first COVID mini repertory within 2.5 months, based on about 150 cases. If you can collect more data with more people, and especially India is an excellent example, and what we did with Ayush, and what also CCRH has much experience with data collection. Well, it could be enhanced more, I think.
I agree. I agree. Right. Thank you.
So, any more?
Sir, if I may add,
Yeah.
I believe that if we can collect, collate, and then criticize ourselves as well, then we will learn better. Then perhaps the data collection will also be better. This is what I just want to summarize that as.
Yes, I think it was a very strong point of your group that they were prepared to criticize each other and to accept criticism and to discuss what might have been the bias in their own perception. And this was very, very new experience for me in the homeopathic world, I must say.
Yes, sir. Our doctors were very positive in taking the criticism, and they took it very well and they learned from it. That was a very good thing. They moved ahead with it.
Yeah, we would never have learned so much about bias as if you wouldn't have done this.
So it was a great team effort.
Yeah, I agree. Okay. Well, thank you all for participating, and I hope to see you. It's evening, especially in India. So we will see you tomorrow, I think. Okay. Namaste.
This is enjoyed a very interesting session.
So, I would like to take this opportunity, first of all, to thank our chairperson. I would also like to take the opportunity to thank our moderators, Dr. Chesta, Dr. Thankraj, and of course, our session coordinators, Gauri Chavla and Dr. Srishti Sudan. And also, I would like to thank all the speakers for being present at the virtual dais. I'll be signing off for this session from Hall 3. I am your MC Himai and time manager. Thank you very much. Good night and namaste to everybody.
Do we have can we have a group picture for us, like
Yes,
just,
yes, sure.
so that we have in the gallery view, so that all panelists are also visible properly?
AV team, can you just click a picture for us and send it to me? He refuses to take with such tense faces. Yeah, that big smile has to be there.
Yeah.
Thank you. Picture taken. Please just forward it to us. Thank you. Thank you, ma'am.
Thank you, everyone. Have a good night here.
Thank you.
Thank you. Thanks a lot.
Thank you all. Thank you all.
We have got with us another beneficiary.
Hello, Halim.
Nice to see you. I was just wondering whether I should chip in a hi or not. Lovely to see you.
We can say hello.
As vibrant as ever.
Thank you. But it's very cold here.
I couldn't judge that.
Yeah.
Right. It's only going to get colder in the coming days.
Yeah. How are you?
I'm good. I'm good. You have some good developments in your life going on.
Yes.
Congratulations.
Yes, thank you.
Yeah, I've been following you on Facebook.
That was a little bit mad, yeah. But also academically. So now I have a university.
Mhm.
So the potential for collaboration is now increased. So maybe now we can start to take things forward.
Oh, that's good news.
Yeah.
Right. Let's just have gather more of it. I think maybe we can have more offline discussions about it eventually. Yeah, let's connect again on this. Yeah, sure. Happy to reconnect.
Yeah, you too.
Yeah, you take care. Take care. Bye.
Bye.